Welcome to part 3 of domestic violence. In this section, we're going to discuss what we can do about domestic violence, both with the patient who is the victim as well as within our communities. In the educational community, domestic violence education is a part of the curriculum for social work, medicine, pharmacy, dentistry, as well as nursing. It's a huge part in law school because, after all, they represent the victim. They also represent the abuser. You will have a big role as a healthcare provider. You have the ability to make very insightful assessments, but you need to be aware that domestic violence is out there. We need to screen our patients universally, and you will find on an admission assessment we have questions related to domestic violence for every woman who comes in. We are the first interface with the patient anywhere in healthcare. So for the OB visit, when they come in for prenatal care, when they get admitted for labor, as well as any emergency room visits. We need to screen for domestic violence at least once each time throughout the trimester. Remember, the father of the baby may not be happy about her being pregnant. If they had an issue during the pregnancy and they split up, the violence may escalate because he doesn't want to end up having to be responsible for a child and he can't stand his mate any longer. We also need to screen at the postpartum visit. We need to let the patient know that when they are within our confines, that they are in a private, safe place. If the partner is always with the potential victim, or somebody we suspect as being the victim rather, we need to dismiss him, make up some kind of an excuse for them to leave the room. When we use an interpreter to ask our questions, we can't be asking somebody who is related to the patient or is involved with the patient. They will not be honest and forthcoming with us because, after all, their abuser may be sitting right there in the room with them. Let your patient know that anything that they say is confidential. However, state law mandates that we report. Keep printed resources available for our patients. So little brochures that actually address domestic violence and safe places where they can go, even if all it is a 1-800 number that they can scratch down on a piece of paper and stick in their pocket or in their purse and use later. So, as a beginner in healthcare, you need to have a strategy of how am I going to feel comfortable asking these questions? Well, some of the tips include watching what words you use. So we don't want to say the word abuse, rape, battered, or violence because these are stigmatizing terms. The patient may look at us because they've been in denial that this is happening all along, and they look at you like, oh no, that's not me. Whatever you do, be as non-judgmental as you can. It is very difficult, so you have to practice your best poker face and voice when asking questions. Find out what your comfort level is. At the beginning, you're not going to feel comfortable at all. But if you have a red flag raised, something that you saw, something that you heard, or something unusual about a patient's demeanor, and you don't feel comfortable asking about it, then make sure you convey this to the healthcare providers so they can take the ball and continue going because they feel a bit more comfortable with it. Also, be familiar with the written protocols that the institution that you're working with has in regards to working with patients that are victims of domestic violence, what are the reporting laws, etc. So when you're going to ask questions to our patients, you need them to be open questions and very broad. You don't want to lead her. So some of the questions you can ask are, well, how are things at home? How are you and your partner relating to one another? Is there anything happening at home that may be affecting your health? And what's interesting about this is when you are looking at the questions that are documented in the chart, our screening questions, they're very ended. Do you feel safe at home? Do you feel safe with your partner? Well, heck, when we ask questions like that, the answer is yes or no. Oh, it's going to be very easy for them to say no. But watch their demeanor when they're answering these questions. Other questions that you may ask are going to be based on what you're observing. What is the patient's demeanor? So, for instance, you seem very anxious and nervous. Is everything all right at home? This is a closed-end question, but you can keep going further based on, is she stalling, stuttering, looking around, seems like she doesn't want to answer. And that's when you need to let her know that everything that she says is kept confidential. When I see injuries like this, I wonder if someone could have hurt you. That's very open-ended. And once again, watch her demeanor. Report it to the physician or nurse practitioner. Is there anything else that we haven't talked about that might be contributing to this condition? This is a very important question. So if we continually ask throughout our encounter with the patient, she's going to notice our concern and is more apt to start coming forth with information. This ends part 3. Go on to part 4.